Good afternoon, my dear students. Today the topic of our lecture is anatomic and physiological peculiarities, method of objective and additive diagnostics of hepatic and biliary systems in children. And we traditionally start with hepatobiliary tract anatomic and physiological peculiarities. So if to talk about liver, what is typical, what is characteristic about the liver in childhood, early childhood especially? Liver parts are unsharply separated. Fibrous capsule is thin with tender collagen fibers and thin elastic fibers. Near 5% of liver's volume are occupied by blood-making cells. Quantity of liver cells is increasing with the age. Liver contains more water and less proteins, fats, and glycogen. Liver's left part is larger than right one at birth. Liver functional condition and its compensatory resources are higher than those ones in adults. And we may also say that normally when the child is born, his lower margin of the liver may jet out under the right costal arc on 5 centimeters even sometimes. And gradually with the age, it's reducing approximately to the end of first and sometimes second year of life. It's reduced to 3 centimeters under the costal arc. Then it's reduced up to 5 years, up to 1 centimeter, and up to the end of 7th year of life, it stays on approximately 0.5 centimeters under the right costal arc. So it means that if you palpate the margins, the liver's margins, up to the age of 7 years, it's absolutely normal event if all characteristics, palpatory characteristics of this margin are absolutely normal. So it may be, but already after 7 years, it shouldn't be anymore jetting out from the right costal arc, and you need to find out what is the reason why it is still jetting out under it. And biliary tract. The biliary tract actually consists of the system of bile ducts, sphincters, which regulate the passage of bile through these ducts, and the gallbladder, like a huge and very important collector of bile. If we're talking about bile ducts, I would like to remind you that they are intrahepatic and extrahepatic bile ducts, and basically the duct which is formed out of the bile ducts, intrahepatic bile ducts, it is called hepatic duct, and that one which comes out from the gallbladder, it is called cystic duct. And when they come together, when they are joining together, they are joined into so-called common bile duct. Common bile duct comes to or falls into duodenum together with pancreatic or Wirsung duct, and it's done through the very important muscular sphincter, which is called sphincter of Oddi. And here, the sphincter of Oddi functions. What does it do and why it's so important? Probably it's one of the most important sphincters in the whole system of biliary passage. So it regulates bile and pancreatic juice flow into intestines. It limits bile and pancreatic juice flow into duodenum in between food intakes. And very important, it protects bile ducts and pancreatic ducts from duodenal reflux. One more time, I would like to remind you that reflux is the backflow or retrograde flow of some fluid, of some contents from one part, from one organ into another one. If you remember in first lecture about upper parts of the digestive system, we have discussed that there may be duodenal-gastric reflux, that once there is retrograde going of or flowing of stomach contents from the duodenum into the stomach, and gastroesophageal reflux when it's backflow of the stomach contents from the stomach to lower esophagus, not just the lower esophagus, sometimes even upper. So here we are talking about duodenal reflux. That's when the contents of duodenum comes through the flabby, lazy, hypotonic sphincter of Oddi to either pancreatic duct or common bile duct. So it's also pathological event and shouldn't be in physiology, in physiological conditions. Bile compound and functions. You see that the bile acids is a great part of bile in general and makes approximately 67% of its contents. It's a very important compound of the bile actually, and bile acids generally provide and support normal consistency of the bile. With all substances which should be soluted, they keep them to be soluted. For example, bilirubin and cholesterol, so they make like a suspension. They are not making concrements, they are not making sediment, and that is supported by bile acid. As far as we have some pathological condition which is accompanied by decreasing number of bile acid, it's accompanied by formation of sediment out of those substances which normally should be soluted, by calcium bilirubinates, by cholesterol, and it's a huge predisposition for so-called cholelithiasis, a pathological condition which is accompanied by formation of stones. So they also are needed for emulsification of fats, very important function. And if there is cholestasis, which is accompanied by decreasing of bile acids because of decreased or delayed outflow of the bile due to some circumstances, there are numerous reasons of this condition, maybe absolutely numerous. So there is a defect in emulsification of fats and their absorption. Intestinal peristalsis increase also is due to bile acids, because bile acids stimulate so-called biologically active substance which is called motilin, which is responsible for formation of the motility of the intestines. And that's why in their decreasing, in their deficiency, motilin is not properly motivated, and it contributes to the decreasing of peristalsis. Also, they are needed for increasing of intestinal tonus, pancreatic and intestinal enzymes activation, pantrophagic bacteria growth limitation due to their unique bactericidal effect. Very often in the deficiency of bile acids, again, which may occur due to different circumstances, but usually due to cholestasis, there is development of so-called syndrome of intestinal bacterial overgrowth, which is too intensive production of those bacteria, pathogenic and opportunistic bacteria in small intestines, which normally shouldn't live there, or should live in very small, minimal quantities, and should be normally suppressed by normal microflora. So if these bacteria start to thrivingly grow and to colonize small intestines, this is called syndrome of intestinal bacterial overgrowth, and it's associated with the development of different dyspeptic symptoms, and also finally may lead in the leaky gut syndrome, which is accompanied by increased intestinal mucosal layer permeability, with the development of malabsorption and different pathological effects related to absorption of weird substances which should be normally absorbed from the small intestines. So take a look. They also are needed for stimulation of gastrointestinal hormones discharge, stimulation of choleresis in the liver. The next substance, and also the role of this substance is extremely important. These are phospholipids, which part makes 22% approximately, and they are first of all needed for protection of biliary tract epithelia barrier. Proteins 5%, and basically these are immune globulins. They are needed for bacteriostatic effect, increasing of vitamins E, D, A absorption. Cholesterol, it makes just 4%, bilirubin 0.3%, and mucus, of course, which prevents bacterial adhesion on biliary tract mucous membrane. Biliary tract anatomic and physiological peculiarities. The gallbladder of infant has a funnel-shaped form. Actually, it's absolutely normal event, and sometimes when you see it on ultrasound inspection, sometimes it may be interpreted as being some pathological event which contributes to the delay of bile outflow, but it's not like that. It's just one of anatomic and physiological peculiarities. The gallbladder volume increases 20 times with the age. Here on this ultrasound image you can find out the septum in the gallbladder. And these are 3 septums in the gallbladder here on ultrasound pattern, but it's not related to what I'm actually talking about. It's just to visualize, to make you visualize how the septums in the gallbladder look like. So bile in children is notable for great amount of water, pigments and mucus. Cholesterol and bile acids concentration is low and increasing with the age. And now again we are talking about those syndromes which may be present related to hepatic and biliary problems. And first of them again traditionally is pain syndrome. And the same what we identically to how we described this pain syndrome for upper digestive system pathological events, all the same principles are actual here for hepatobiliary disorders. First of all, we need to identify localization of pain, periodicity of pain, character of pain, its irradiation, provoking factors, and those factors which help to remove the pain. I will give you a short sample of how, for example, it may help us. The child is suffering, is complaining of acute, attack-like, sharp, spastic-like pain. Usually it's short-termed. Epicenter of this pain is right hypochondrium. Usually it is provoked by intensive physical training, especially jumping, running for long distances. Sometimes it's provoked by stress. It's irradiating to usually right forearm and arm. And it's effectively removed by application of something hot, usually hot water back, to the right hypochondrium in the hot shower, and sometimes also it's relieved by some tablet which a school nurse gives to this child. So being based on these characteristics, just characteristics of the pain, you already can understand that in 90% you will be right with the diagnosis of hyperkinesia of the gallbladder. Hyperkinesia of the gallbladder, that is pathological condition which is provoked by over-intensive over-contraction of the gallbladder, too intensive, when it becomes spastically contracting. So how could we understand it out of the characteristics of pain? First of all, spasm in any part of smooth muscles, spasms in any part of our body, in any part of our organism, they give us quite common, quite typical picture, clinical picture. What is this pain? Now, what is this clinical picture? This is spastic, acute, attack-like, quite sharp, but usually short-termed pain. So these are attacks of sharp, colic-like pain. So due to this characteristic, we understand that probably we deal with spasm. This spasm, or when it is localized in the gallbladder, usually typically irradiates to right part of the body. Not always it's just hand. It may be right scapule, right part of the trunk anywhere, and sometimes even right part of the neck. Also that fact that physical loads, especially jumping, is provoking this kind of pain. It's actual for hyperkinesia of the gallbladder. And also we can understand that it's probably spasm because it's relieved by something hot, but hot shower, because something hot, it helps to relaxate, to relax the smooth muscles. And that's why when you apply something hot and they are relaxed, the spasms are removed and the child feels that the pain is relieved. This tablet, this wonderful tablet given by a school nurse, that is usually drotavirin or platifilin. That is the tablet which can be easily given without any receipt by a school nurse, and that is the most widely used drug at school in general. So that is why on the background of these characteristics we can already make predominantly the diagnosis. Everything you should do to confirm the diagnosis you guess, you suspect, is just to carry out appropriate instrumental investigation to exclude some more severe organic pathology, and your diagnosis will be ready. Dyspeptic syndrome. Here, what can we have? Hepatobiliary disorders. There may be nausea, vomiting, bitter taste in the mouth, skin itching. What are these, for example, symptoms such as bitter taste in the mouth and skin itching related to or caused by? Quite often syndrome present in case of hepatobiliary disorders, actually that is more biochemical syndrome, but it's often presented clinically as well. That is cholestasis syndrome. That is when the bile is staying inside either intrahepatic or extrahepatic bile ducts, or in a gallbladder, or in common bile duct, independently where it's not moving, and especially when it's staying inside the gallbladder, the components of the bile becomes to absorb through the mucous membrane of the gallbladder and appear in the bloodstream. The bloodstream spread them all over the organism. They accumulated in skin, causing itching. They accumulated in mucous membranes, for example, in the oral cavity, given this specific bitter taste in the mouth. Or also some children feel it as not bitter taste, but they describe it as something metallic in the mouth. It's more remarkable in the morning. Why? Because during night it was no food intaken, so it was no contraction of the gallbladder, and that is why the bile components were more intensively absorbed, and up to the moment of awakening from the sleep, the child feels this bitter taste or metallic taste in the mouth. And skin itching, that's due to accumulation of bile acids in skin, irritation of receptors, and due to this irritation the child feels necessity to be itching. Also another syndrome, syndrome of jaundice. Jaundice is yellowing of mucous membranes and skin due to the increased level of bilirubin, which is called hyperbilirubinemia. And also there may be different reasons different reasons of jaundice in general. They may be related to liver problems, to the problems of biliary ducts, and maybe not connected to it. For example, like it's typical for hemolysis. Hemolysis causes us direct hyperbilirubinemia, increasing of bilirubin due to, indirect fraction. And if we are talking about liver diseases and biliary diseases, usually icterus is caused by, again, cholestasis, when bilirubin, which is already converted from indirect to direct fraction in hepatocytes, so when direct bilirubin is arising in bloodstream, causing development of jaundice. And it may be also related to, for example, insufficiency of the liver cells to convert indirect bilirubin into direct bilirubin, and as a result indirect again bilirubin is accumulating in the bloodstream and causing jaundice, and so on and so forth. So in all of these cases the child gets yellowish shade of skin, mucous membrane, or just mucous membranes. Usually when skin is untouched but mucous membranes are colorated in yellow, we are talking about subictericness. That is not complete jaundice how it is, but it already testifies that the child should be properly examined on hepatic, biliary, and non-hepatic problems. hepatobiliary syndrome, that is enlargement of liver and spleen. And usually if we are talking about liver diseases, we mean of course those ones which are accompanied by development of portal hypertension, which is one of concomitant signs of liver failure. And as a result of this, there is enlargement of liver and spleen. If we're talking about enlargement of spleen, usually it is associated with hypersplenism, which as a result, as one of the consequences, have pancytopenia, decreasing of erythrocytes, thrombocytes, leukocytes. And sometimes enlargement of liver and spleen are so remarkable that they may be easily detected at oculus when you are just looking at the child. You don't need specifically palpate the abdomen in order to find out. You don't need to carry out ultrasound inspection, but they are so large that you can see them in general inspection. And finally, again, intoxication syndrome, I will repeat it one more time. It contains absolutely non-specific signs, which include headache, weakness, flabbiness, body temperature increase. Which methods should be prescribed in order to diagnose different problems, different pathological conditions with biliary and hepatic systems? For example, the first one and the most common is clinical blood test. What can we detect with the help of clinical blood test? First of all, inflammatory changes. They are traditionally associated with leukocytosis, increased amount of leukocytes. It may be due to neutrophils if we're talking about bacterial inflammatory process, or they may be associated with increasing of lymphocytes, which is more specific for viral process. It's also increased erythrocyte sedimentation rate. It's one of non-specific markers of inflammation. And if we're talking about, for example, liver failure, when the factors of coagulation can't be normally produced, synthesized here due to hepatocellular insufficiency. There is development of different sorts of bleedings. And of course, these bleedings will be associated with post-hemorrhagic anemia. In this case, you will find out signs of anemia like decreasing of red blood cells and thrombocytes, and it will be also associated with the hyperregenerative ability of the bone marrow, reticulocytosis. If there are persistent chronic bleedings, the regenerative ability of the bone marrow will be exhausted with the time, and it will be regeneration, hyperregeneration or regeneration developing. If we're talking about hypersplenism, we have mentioned about, there will be decreasing of all cells with development of pancytopenia, leukocytopenia, thrombocytopenia, erythrocytopenia. If we're talking about clinical urine analysis, actually you can find out different urobilinogen here and bilirubin derivatives present here. It's not very specific, but like the first line diagnostic method, it can narrow the spectrum of our diagnostic search. Biochemical blood test. Biochemical blood test in many cases is very important and very indicative on some certain pathology. Basically, you should know exactly, and you will study these biochemical syndromes in practical classes, but you should know them by heart, these biochemical syndromes, with the help of which you can understand which pathology is more probable in this or that case. For example, first pathology that is cholestatic syndrome, or syndrome of cholestasis. We have partially already discussed this syndrome, and what is that? That is accumulation of bile with violation of its passage from the bile ducts. So that's why the basic biochemical markers which you can detect in your biochemical blood analysis are increasing of bilirubin due to direct fraction, increasing of alkaline phosphatase, and usually it's quite remarkable increase. Also, there is increasing of gamma glutamyl transferase, it's another enzyme, increasing of cholesterol. and increasing of bile acids, of course. So all components of the bile which are absorbed in case of cholestasis, they appear in the serum blood in the increased quantity, and you will be able to understand, to differentiate that there is exactly cholestatic syndrome. Second syndrome, it develops in acute, very active process of affection or destruction of the liver cells, hepatocytes. It is called the syndrome of cytolysis. And as far as we are talking about destruction of liver cells, we can say that all enzymes which are living normally inside the cells are going to be increased significantly in this syndrome. And first of all, these are of course liver transaminases, which are ALT, AST. These are aspartate aminotransferase, and alanine aminotransferase. Also, apart from them, it may be increasing of aldolase and lactate dehydrogenase. And apart from these, also another substances which normally live inside the liver, which are, for example, ferritin, which is B12, which is iron by itself. So their levels also are going to be increased due to the destruction of cells. So cytolytic syndrome is typical for any acute or primary stages, active stages of affection, alteration of the liver cells caused by actually any process, viruses, for example, drugs, in case of medicamental or toxic hepatitis, different chemical substances. In elder children, it may be also alcohol. Unfortunately, in our country, it may be also, and so on and so forth. Then, next biochemical syndrome, it is called the syndrome of hepatocellular insufficiency. That is when the liver cells can't anymore to compensate some pathological process, can't fight, and they give up, and that's why it's accompanied with exhaustion of their functions, total exhaustion, and total depression of the functions of the liver cells. It's easy to understand which markers, biochemical markers, will accompany this syndrome if you know which functions of the liver are typical for this organ. For example, due to the deficiency of protein synthesis, it will be hypoproteinemia. It means that the total protein in serum blood will be decreased for less than 60 grams per liter. Normally it should be between 60 and 80 grams per liter. It will be hypoalbuminemia. It will be decreasing of prothrombin and synthesis of coagulation factors. They all will appear to be decreased. Also, it will be decreasing of cholesterol, because the liver is that organ which is responsible for cholesterol synthesis, right? It will be also hyperbilirubinemia. Here we have hyper, something